extremely broad experience in neonatology as well as pediatric education since last 35 years. He has established various programs in pediatric as well as neonatology, like DNB programs, fellowship programs. He is the one who has started MRCPCH clinical examination for the first time in India in 2011, and since then he is regularly conducting those exams. Not only that, he also has a great academic contribution. He's almost reaching to nearly 100 publications and abstracts, and he's written 21 chapters in the various textbooks of neonatology as well as pediatric. And sir, recently there is a popular book published called Evidence-Based Approach to the Neonatal Respiratory Disorders in 2020, and sir is the author of that book. So with all this background, I would like to welcome Dr. N. Karthik Nagesh sir to start today's session.
Thank you so much for this kind introduction. Am I audible, Dr. Prashant?
Yes, sir.
Yes. Are my slides also visible now?
Yes, sir.
I'll just switch to the slide mode. Just 1 second, please. So it's indeed a proud privilege and a pleasure to be
So the voice is slightly low. If you can just.
Yeah. Can you hear me better? Can you hear me better?
So it's same.
It's maybe I'll just. Can you hear me better now?
Yes, sir.
Yeah. I'll just remove this earphone. Yeah. So it's indeed a proud privilege and a pleasure to be talking at this forum. In fact, I must thank Dr. Somsekhar Nimbalkar and Dr. Prashant Karya for inviting me here. Thank you, Professor Dipen Patel and Dr. Reshma Pujara and all the NNF executives of Gujarat State Chapter, where many of my students have been faculty in the various medical colleges and hospitals there. It's indeed a proud privilege to be talking at this forum. The care for respiratory problems in newborns has almost been spanning over the last about 60 years or so. And I'm so happy and proud and privileged to be part of this care for the last almost 40 years in this part of the country. The first 10 years of my decades of neonatal experience in this country has been as a student, starting from PGI Chandigarh, where I was a pediatric trainee, and then subsequently at Delhi's Safdarjung Hospital and All India Institute, and then, of course, in the UK. So about 30 plus years now, I have been able to provide newborn services in this country, where also some research has been inculcated. And now, last about 25 years, we are doing a lot of newborn training as well. And more than about 400 graduates from neonatal training have graduated from our tertiary care unit here at Manipal Hospital in Bangalore. Now, why I mention this is the journey of respiratory care in newborn medicine has almost very similarly happened in this last 4 decades in this country. From the earlier decades in the early 90s, when we were able to set up early tertiary care neonatal ICU services for preterm RDS and other issues in bigger babies, the first surfactant treatments were done by us. Subsequently, there was a great exposure for us in terms of doing other intensive care measures like introducing ECMO, diagnostic fiber optic bronchoscopies in babies, starting TPN protocols, starting neonatal transport services, even air transport, inhaled nitric oxide, high frequency, and therapeutic hypothermia. Whatever you name it, we have been able to do. Some of us have been blessed. Some people like me, some same generation, Professor Ashish Mehta from Gujarat has been similar generation. We've all been blessed to have gone through entire gamut of newborn intensive care, the hardcore intensive care. But what brings me back to this topic of today is, as far as preterms are concerned, we have realized over this last 40, 50 years or so that we don't necessarily need to be that aggressive. And I'll tell you the reasons why. No doubt, preterms are the reason why most of us have been doing neonatology. Increasingly, we have been seeing that preterm growth rate in India, especially, has gone to almost 15% of the babies are preterm. Now, if you look at all the cohort of studies done in this last 3 decades, if you start the NNPET data, almost 55% of the babies have died in the newborn period due to prematurity and related complications. So you can't run away from preterms. The Dennis cohort, which was published subsequently in 2011 to 2014, this is the Delhi data, which suggests again, preterms are the primary reason why babies were dying because of complications related to that. And the recent data also suggests, which is published last year in Perinatology, suggests that it's preterms which are the reason for death most of the times. So all the time, when early 90s, we have had an arduous task of setting up neonatal ICUs in this country. We are a very handful of newborn intensive care units. We had old, redundant, now newborn ventilators. We would ventilate babies. We would probably have the exigencies of circumstances where much against all odds, we're trying to most of the times look after preterms, because even then, 50% of the times babies would get referred to a tertiary care neonatal unit, like anywhere in the country, would be because of prematurity. Of course, those days we were seeing larger and larger babies with probably gestations of about 28 to 34 weeks most of the times. But then in today's world, we are getting to look after babies smaller and smaller. This is data not now. About 8 years ago, we had the opportunity to look at the data from India. India has really caught up with the rest of the world as far as intensive care treatment is concerned. You have everything in a tertiary care unit like ours, for example, and thousands such units are there in this country as we surveyed that time. Even in the government sector, the NHM, because of the funding available through UNICEF and other agencies, more than about 1,000 now SNCUs are available where you can ventilate babies, give surfactant, and do the best possible cares, including peritoneal dialysis, and even go into higher modes of ventilation like high frequency, even in the government sector, and nitric oxide as well. So the question is, where are we as far as looking after these babies and the survival is concerned? I must tell you, this is data which was, of course, 5 years old, though it was published only recently. We, in high resource situations, gestations of 30 weeks and less, are able to match up almost to the similar situations in tertiary care units in the Western countries like the UK. Gestations 28 weeks and above is no big deal for us. It's not rocket science anymore. We look after babies with almost 100% kind of acceptability of survival. Whereas in extreme preterms who are 26 weeks of gestation or less, we find that we are still to go there. But this is data, as I said, 5 to 6 years ago. And now, today, I can tell you in high resource situations, even in our country, gestations 25 weeks, 24 weeks, we are almost at our par with units in the Western countries. Now, most of the reason why this has happened is good respiratory care based on evidence-based principles. If you look at all the technologies, all the protocols, systematization, whatever protocols we have for infection control, nursing, a lot of therapeutic adjuncts like surfactant, etc., most of it translates into the fact that preterm care has improved because of good respiratory care and due diligence in that aspect. Now, it all started, the journey started in 1956, maybe with Professor Mary Ellen Avery, who suggested through her research that it was surfactant deficiency in the baby's lungs, which was leading to RDS in preterms. More research happened because especially after President John F. Kennedy's baby died at late gestation of 34 weeks, baby died because of severe RDS in Boston. A lot of money was pumped into research into trying to treat respiratory distress syndrome. And that is when in the early 60s, ventilation became a mainstay. And that was one reason why babies improved in survival. The neonatal mortality really decreased because of ventilating babies. Very, very surprisingly, even at that time, early 60s, a lot of data emerged on the use of CPAP, but that was forgotten because ventilation became very prominent, and the next 2 decades is all ventilating babies all the time. Of course, in between, the other remarkable success which happened was surfactant was analyzed, synthesized, and also extracted naturally from the lungs of the cows. And Fujiwara from Japan suggested that it's a very good modality to improve baby survival. So, of course, subsequently, a lot of research went into surfactant, and now it's become a mainstay of treatment. Surfactant, I think, was another reason why infant mortality dipped quite significantly. Surfactant biology was very, very well researched in animal models. It was clearly determined that less surfactant, if it is there in a lesser gestation baby, more the chances of RDS, and more surfactant in gestations nearing 35 weeks, you will have less chances of respiratory distress syndrome in the babies. Surfactant biology was well analyzed. Every component of the surfactant molecule was analyzed. It was found very clearly that the DPCC is basically the reason why surfactant keeps the lungs open in babies and reduces the surface tension, and it optimizes the mechanics of breathing and prevents the alveoli from collapsing in preterm babies. And of course, surfactant proteins A, B, and C are there to help optimize the effect of surfactant. All this research has happened in the mid 80s and mid 90s. Professor Alan Job, Professor Jeff Whitsett from Cincinnati, they were probably the pioneers in doing research work in surfactant in experimental models and then translating it to clinical models so that today we're able to use it and babies are being saved. So this is a great paradigm shift in the care for respiratory RDS in preterms, which help babies recover. It was very clear that the more preterm the baby, more surfactant deficiency, surfactant pool is less. Combined with the structural immaturity of the baby's lungs, there's progressive atelectasis because FRC is not able to be maintained. A child goes into progressive hypoxemia, hypercarbia, and acidosis, and unfortunately, the child succumbs. But on the other hand, research suggested that if you were to give antenatal steroids, it improves surfactant production, surfactant maturity is improved, surfactant pool increases in the baby's lungs. And if you were to give it exogenously to a baby who may be delivered prematurely with a poor lung structure, still you give surfactant, though the baby may have acute lung injury in the form of severe inflammation, pulmonary edema, still surfactant would help and the child's severity of RDS will come down and the child will survive. So coming to this journey of what has been the therapeutic modalities available for respiratory distress in preterms, the early 80s, people were all confused. When I was a resident, all we had was oxygen to do. Even now, in the periphery, if you see in low resource situations, that's all you have to do. You have no other facility available. All of us would, even now, in the periphery, see babies being given just oxygen with head box, no monitoring, just a nasal cannula is going into the baby, no monitors. And mind you, only in the late 80s did this pulse oximetry come about, which is now so ubiquitously available. And now we have clear evidence that if you oxygenate the babies severely, there would be higher chances of lung damage to the baby and also problems in the eye. So the first forays into neonatal ventilation as what we call is modern ventilation happened in three major institutions in this country. Luckily, fortunately, I was associated in my training in all these institutions. And one of the few private sector hospitals where we started ventilating was where I'm working now for the last 30 plus years. If you look at the pre-surfactant era in this country, you will find gestations even as good as 28 weeks. Today's day, we don't really worry too much about 28 weeks. Look at this baby. Typical example, stormy course, antenatal steroids, we have not even heard about this. Child is hypoxic and acidotic. The child has this rudimentary old type of ventilator, the pressure limited ventilation, where there's no control on the volume at all, and it's a time cycled ventilator. The baby was aggressively ventilated, and unfortunately, the child needed oxygen and got discharged only at about 3 months of age. We really didn't know what was happening. We really didn't know those days what is the chronic lung disease all about. So the first use of successful surfactant was published by our unit, and we had this baby at that time. Babies who were being given surfactant, and immediately low and below, behold, you would find that oxygenation is not needed so much. The amount of ventilation is coming down rapidly, and you are able to extubate the babies off within 3-4 days. The first surfactant we used to get was imported from other countries without any major licensing. The actual licensed product of surfactant came into this country only in the late 90s. So these are all surfactants many of us were using directly imported through some distributors, and they were being used for these babies. So that was the scenario in those days. But then surfactant became quite popular, and most of us were using these surfactants, and babies are getting better. Parallelly, lots of new technologies happen because we are giving surfactants. The baby's lungs will be better, no doubt, but ductus would open up. So you have EDA ligations which started coming into foray. You would have babies who are not responding to surfactant, maybe even bigger babies. We started introducing nitric oxide into our systems. High frequency oscillation started coming in. Babies were being air transported sometimes after birth, babies. So all this was a very dynamic situation happening in the mid 90s to the mid 2000s, and many neonatal ICUs across the country sprouted, And in every city, there was a good neonatal unit doing all these kind of treatment. It was really like a cascading effect with all these technologies happening. But what we were not able to understand still is, here is a preterm whom we are gestationally, no doubt, even smaller gestations, even for example, look at this baby, 25 weekers we're accepting. We'd say, hey, we have ventilation. We will be giving ambu bag 100% oxygen ventilation to these babies, and we will find the baby's not getting better, and the lungs will be looking like this, like typically severely afflicted cystic kind of changes in the lung. We still wouldn't understand what is happening. 4 doses of surfactant given, we don't know what's happening, and a child requires treatment for 4-5 months in the ICU, sometimes as long as even 8 months, like in this baby, where I had to air transport this baby to the US and subsequently ventilated. Even they didn't understand. For a long time, they ventilated the baby, kept the child on oxygen, and finally the child came out. That is around the time we realized that inappropriate, prolonged ventilation of a newborn can be probably more harmful than the disease itself. A lot of us were starting to ask ourselves the question in the late 90s and early 2000s, whether we should be aggressively ventilating the smaller babies or not, and whether it may be doing more harm than good to the babies. So this is something experimentally also got sensitized into many of us. Rabbit models, rabbit lung models were published by Alan Jobe and many, many great researchers. They would say, look at this picture, the pathophotomicrograph of a baby in the rabbit lung. You'll find that no ventilation, the lung architecture is preserved. 24 hours down, you'll find the lung architecture is disrupted. You'll find less of alveoli, less surface of the lungs available for oxygenation, and you can see the cystic changes. This was what then we started recognizing was called BPD, or chronic lung disease. And etiologic association, we all started realizing, was there is a predisposed baby who's immature, has severe RDS. The lung disease is so severe that there's fluid overload sometimes. We didn't also know that at that time we had to be very careful with fluids. The ductus arteriosus would open up, the babies will be flooding the lungs more with lung fluid, and the babies would have more chronic lung disease chances. Contributory factors like chorioamnionitis in the mother were contributing. We'll also find that sometimes, in spite of giving surfactant, the baby is not improving, probably because of some kind of deficiencies in the babies, which is not allowing them to synthesize their own surfactant. And these babies were requiring high levels of respiratory support, leading to possibilities of oxygen toxicity and barotrauma. That is exactly the time, about 20 years ago, when we started realizing that these words like barotrauma and oxytrauma are likely to be causing what is called the BPD. The old BPD is what I was describing to you just now, where typically babies would be getting afflicted because of the stress, because of mechanical ventilation, whether it was barotrauma, oxidative stress, or what you call whatever other forms of trauma, coupled with infection, maybe like chorioamnionitis, poor nutrition in the baby, leading to a severe inflammation in the lung, causing tissue destruction and fibrosis. But then people also started realizing that sometimes the babies were developing their lungs, and suddenly you disrupt that development while the process of alveolarization and vascularization of the lungs has still not occurred. The child will go into a form of chronic lung disease that is called the new BPD. Whatever, whether it's the new BPD or the old BPD, we started realizing about 20 years ago that chronic respiratory and cardiovascular insufficiency would lead these babies to develop poor exercise tolerance. These babies will get recurrent infections in the lung. They'll have poor physical growth and even neurodevelopmental impairments. So this is what we were seeing somewhere around 15 years ago, and we are not able to understand what to do. So no doubt, multiple NICUs all across the country and across the world were mushrooming up, but babies were still living in the NICU for 4 months, 5 months, needing oxygen, and we're not sure what was happening to our newborns. So that is around the time 15 years ago, 16 years ago, we realized this is something called ventilation-induced lung injury. Whatever you call it, people started using words like barotrauma, the pressure affecting the baby's lungs. People started calling it volume trauma. Maybe the lung is getting over-distended, and that is the volume trauma causing this. Rheotrauma is flow, excessive flow through the ventilator is possibly causing it. Endotracheal intubation causing damage to the airway itself was causing endotrauma maybe. Biotrauma because of the cytokines which are being formed by the lungs because of lung injury, that was possibly causing a damage. Or sometimes it was felt that if you were to allow the lung to suddenly collapse and expand, that was causing atelectasis, and that was possibly causing damage to the lungs. So all these were speculations. We even realized at the basic lung wall model, if you look at it, just a few hours or a few minutes of intubation and ventilation that would cause acute lung injury. Look at this small model of an alveolus here. This is the interstitium here. These are the blood vessels. And we found that even a little bit of acute lung injury causes flooding of the interstitium with cytokines, inflammation, and this fluid would leak out into the alveolus through a deranged capillary membrane here, flood it with proteinaceous alveolar fluid, and as a result of it, the lung would become absolutely stiff, and surfactant, even if given, would not work. And these babies were really getting into the typical situation for developing chronic lung disease. So at that time, we thought probably it was all due to barotrauma because of excessive pressures, because we're using pressure limited and time cycle ventilators. So we'd be all the time wondering how to reduce the pressure for these babies. But the best thing which happened somewhere around the late 90s was we thought right at the time of delivery, this acute lung injury is probably causing these problems to the small preterm baby. So we started using, and at that time, our own Indian research suggested from Delhi's Maulana Azad Medical College suggested that oxygen is toxic to term babies as well as to preterm babies. So we started using oxygen carefully. We even started bringing a pulse oximeter into the delivery room and started ventilating babies, not with an ambu bag, but with a T-piece resuscitator. Today, what you see is a T-piece resuscitator where you can set the PIP and the PEEP very carefully and start gentle positive pressure ventilation, and using some permissive hypercapnia techniques, you would probably cause less trauma to the baby's lung and prevent the acute lung injury or the chronic lung injury which was happening to these babies. While this was all going on, we also realized that if the baby is breathing, intubated and breathing out of synchrony with the ventilator, there would be not only effects on the blood circulation in the brain, there would be high chance of air leak syndromes, ineffective gas exchange, all this contributing to the development of chronic lung disease. So some of us very early on got into patient-triggered ventilation. These devices were available then in the early 2000s. You will have this adaptation connected to a ventilator, wherein a small catheter will go, it's a pipe-like thing, which will go onto the baby's abdomen. So when the baby would breathe, the ventilator would sense the baby's breath and give a breath to the patient. This is called patient-triggered ventilation. But much more refined systems are now available. Last 15 years, modern ventilators, they can be set on the assist control or SIMB mode or whatever, PSV mode or whatever you have. So when the baby is breathing, it synchronizes very effectively. So this is able to sense the flow or the pressure inside the ventilator circuit and deliver the baby to the baby's breath to the baby only when the baby is having an inspiratory mode and trying to terminate when the baby's expiration is happening. So all this was probably helping babies, and our incidence of respiratory complications to chronic lung disease came down. We also started getting a lot into pulmonary graphics, and we said, hey, we don't want the baby's lung overexpanding and overdistending. So we started looking at the dynamic compliance. We would have these graphics coming in a pressure volume loop or whatever loops you would have on a ventilator, and we'll go according to that. But all this was not still happy. We're not happy enough. We even tried high frequency ventilation. Some of these studies published in the mid 2000s suggested as a primary mode, you should start high frequency oscillatory ventilation in preterm babies, where the map which you'd use for the baby will be very less. And therefore, because the tidal volumes generated will be smaller than the dead space, you will have easy, this is, for example, this is the pressure volume loop. You will find that this is the way the ventilation would happen. You would not overdistend the lung, neither the lung is allowed to collapse. And this is a very gentle form of ventilation, the baby with high frequency. Again, not a happy situation, because high frequency ventilation, the HI-FI trial, which was published 20 years ago, suggested that if you use it as a primary modality of respiratory support for a preterm, it would cause a higher incidence of intraventricular hemorrhages. So we abandoned it. We used it only for rescue in the event the child has severe lung leak or air leak syndromes like pulmonary interstitial emphysema, we would probably use it only for that situation. So around mid 2000s, we started realizing we have to achieve good lung recruitment. So we had to maintain an open lung strategy, what we call keeping a high PEEP, keeping the lung at FRC, minimizing the tidal volume as much as possible by reducing the pressure which we deliver. So all the time we'll be looking at the baby's bedside, looking at the chest wall movements, looking at the air entry, looking at X-rays and seeing, hey, I hope I'm not over-ventilating this baby. Blood gases all the time we'll be doing, looking for CO2 washouts, and we'll say, no, we don't want to wash off the CO2 because it leads to more lung disease. We'll probably reduce the pressure and keep the CO2 a little high. It's called permissive hypercapnia. We'll do a lot of synchronization of the ventilation. We'll probably repeat surfactant dose. We'll even switch to high frequency oscillation, keeping all this in mind that we are probably careful about barotrauma and providing ventilation-induced lung injury. Around the same time, the wonder drug caffeine came, and caffeine was remarkable in trying to tell us that if you were to use it early enough in a preterm, gestations of 34 weeks or less, even if the child is ventilated, you will help improve survival without BPD. And not only it was a drug good for apnea of prematurity, it helps improve the chances of not getting BPD, apart from improving, now data suggested that it improves neurodevelopmental survival. But this was something which was revolutionary. And mind you, this is the crux of my talk today. I have set the pace to talk to you about what you see as such a simple technology solution happening to help babies survive better is something which Professor Wong, who in 1997 proposed it in his papers. Professor Wong was sitting in the middle of busy New York City in Babies and Children Hospital at Columbia University. He was just doing bubble CPAP, trying to keep the baby's lung open in a spontaneously breathing preterm by giving aminophylline. In those days, caffeine was not available. To improve the work of breathing, giving aminophylline and keeping the lungs open with CPAP. It took him 10 years to convince people who are all, we're all happy, gung-ho about high frequency oscillation, synchronized ventilation, this and that. And this gentleman was quietly doing studies, sitting in New York, Columbia University, and saying, this is what helps babies better. And this is what we have realized over many years now keeps us better. Now, the COIN trial probably changed everything. Professor Colin Ponley and his group from Australia published it. He said, respiratory distress, let it start. And at 5 minutes after birth onward, they started giving CPAP, either this or intubate and surfactant. And they found that in 50% of the times, if you just give CPAP, you can avoid giving ventilation or surfactant to these babies. What a remarkable thing this COIN trial tried. Our whole practice changed, followed by the prophylactic CPAP group, which was the support trial, which again suggested that if you were to prophylactically in an extreme preterm gestations 24 to 27 weeks, you start CPAP in the delivery room itself, 33% of the times you don't really need to give surfactant in these babies or to intubate them at all. This changed our practice, so much so one of our theses, which got later presented at the European Society for Pediatric Research, really suggested that we can probably do with extubating babies electively after giving surfactant and not continuing them on ventilation for long time, like what we were doing at that time. We're just continuing ventilation for a week or so. On the contrary, when we extubate them to CPAP, we found that the need for oxygen dependency and the need for ventilator dependency came down significantly. So this was something very in a small way we also showed that if you were to start even delivery room CPAP at the time of delivery and subsequently to a TP's resuscitator, if there's any kind of positive pressure required, you can do positive pressure ventilation without using an ambu bag or any kind of self-inflating device. And at this time, somewhere about 10 to 12 years ago, we started using air and oxygen blenders. We till then were giving even TP's resuscitators with 100% oxygen. That was not good enough. We are all the time worried what is going to happen to the baby's lungs or the eyes. And this is around the time about 10 years ago when the blender started coming. So we start with small doses of oxygen. We didn't have clear guidelines, but we also got at that time, because of the oxyprom studies, very clear guidelines on what are the delivery room saturations we expect in a preterm or a term. So we would have the targets available for us at the delivery, and we would do resuscitation in the delivery room or subsequently taking the baby to the NICU on CPAP. We would intubate very rarely, only if the baby was very apneic or had excessive gasping. So this is what now all of us follow now. If you see in this video here, we are just giving positive CPAP pressure to the baby. We are monitoring, we are using an air and oxygen blender, which should be available in every delivery room now. And we have a simple pulse oximeter kept on the pre-ductal side, trying to keep an oxygen check on these babies and trying to maintain target saturation and achieve it by about 5 minutes of age. And this is now the protocol most of us are now following and trying to keep the oxygen 90 to 94%, reaching it in the delivery room by 5 to 10 minutes, and then shifting the baby to the delivery to the NICU. This is around the time, somewhere about 10, 12 years ago, a lot of early data suggested that if you bring the baby back to the NICU as a primary modality, NIPPV through a ventilator with a mask is probably better than just giving CPAP. So either way, it was very, very clear that CPAP or NIPP was better in making sure the baby doesn't have a higher incidence of BPD rather than giving intubation and ventilating the baby. So this became fairly clear to us in most of our publications this last 10 years. We've been talking mostly about NIV. So you can imagine me as a critical care intensivist starting from aggressive intensive care. I'm now convinced this last 12 years that less is more. That is exactly what I've been wanting to point out to you. All this time, I've been talking about what aggressive we have shown. On the contrary, now, all we say, and I tell all our registrars and residents, don't ventilate if you can avoid it. If at all, just give nasal ventilation by NIV. Intubate if there is a need, definitely, for example, congenital diaphragmatic hernia, meconium aspiration, bad, PPHN, if there's an airway problem, or you're doing an exit procedure for some mass like a chaos or something where the baby is delivering, or severe hypoxic encephalopathy. So most of the times, as far as preterms are concerned, whether it's an extreme preterm baby also, gestation, sometimes even up to 24 weeks we look after now, and we are still giving them most of the time CPAP or NIV. Again, this is reiterated by the fact that when you look at the pressure volume curve and we are ventilating babies, two things which are causing lung injury nowadays is very clear. This is what is a modern concept now. It's a volume trauma. You're over distending the lung, and that is what is causing that. And also you're allowing the lung to collapse. That also should not be allowed. So you should keep a PEEP and should keep a PIP, which should not let the lung over distend. So this is a concept brought down by Professor Martin Kessler. We all had a great opportunity. Most of the senior neonatologists in the audience or in this country would have listened to him when we had a very nice Hippocrates symposium at All India Institute about 15 years ago. All of us got convinced that you have to, if at all you need to still ventilate babies, you have to do volume guarantee or volume targeted ventilation. All these ventilators now have microprocessors in them. You set a tidal volume, and by chance, if the ventilator has had to give a higher pressure in the previous breath like this here, it corrects itself, and the next breath, it gives a lesser pressure than what is given, because the target or the what we call the target pressure you've set, you should not allow it to be exceeded so that the volume doesn't get more and the lung doesn't get over distended and cause volume trauma. So most of us now, as most of you in the audience would also have seen, we are just doing volume guaranteed ventilation. The best advantage of this is even if you're ventilating a baby, it keeps the volume normal so that the baby's lung doesn't get over distended, and therefore the child, as the compliance improves, the pressure starts coming down. That's why it's called an auto weaning mode. Most of the modern ventilators, when you set a target tidal volume, it slowly automatically weans the PIP or the pressure, and you get away without needing to ventilate the babies long. And you really are not very stressed out while you're ventilating babies, because the ventilator decides how much pressure to give, and it doesn't exceed the pressure which you have set, the upper, what we call the working pressure. Now, the other kid on the block this last decade has happened, which is much, much more simpler, is high flow nasal cannula. And people like Ram, who has been a close friend for 20 years now, they were the innovators in this. Most of you are now using this high flow cannula device. There are 3 devices available, the OptiFlow or the Ram cannula or the Vapotherm, which is more popular in the UK. Basically, it just allows with a simple device like this, high flow is going into the air and oxygen blend is going into the nose and the nasopharynx of the baby. It just washes off the carbon dioxide. The gas exchange is actually taking place at this level, not necessarily in the lung. It's happening in the nasopharynx. To some extent, it does give a little CPAP, but it is not a CPAP device. It is only a gas exchange measure and to give good oxygenation, but it does reduce the metabolic work associated with gas conditioning. So most of us are now sort of sold to this idea because it's so easy to use. Nurses and mothers, all of them like it. It minimizes nasal trauma. It has got its uses now in bronchiolitis. Definitely, data suggested, especially the hipster trial, which was done about 8 years ago, suggests that as a primary modality for gestations above 28 weeks, it can be used, but not gestations less than 28 weeks. But as a secondary modality, that means you've got the baby off the ventilator or off CPAP, you can go on to high flow nasal cannula for the next many weeks till the baby is ready to go home. So if you now see the significant progress in respiratory therapies which have occurred from the times when surfactant was first discovered, then on to mechanical ventilation, a lot of research on surfactant. Antenatal steroids made a big difference in the mid 90s that came about, and now almost it's ubiquitous. Antenatal steroids definitely improve the surfactant production and surfactant maturity, and that's made a game change. If you need to still ventilate babies, we are still doing CPAP, but then you do volume guarantee ventilation. And this last decade or so, most of us are giving CPAP only or high flow nasal cannula. If we need to still give surfactant, we are going to usually use less invasive modes of surfactant. Now, this is a very nice slide, which I thought you should see. If you look at white matter damage, or if you look at chronic lung disease, even a few hours of ventilation makes significant damage to the lungs or the brain. If you keep this slide in mind and say significant damage can occur to a baby's brain or lungs, if you just ventilate them for a short while, causing this damage, it's not good for the babies. If it's a preterm baby, lesser the more the prematurity, more the worse damage. So this is something you ought to keep it in mind. So the NNF, and I had the fortune to be the reviewer for the NNF guidelines year before last, and it clearly has brought out this concept that we should have non-invasive respiratory support for babies, advocated most of the times in high resource situations or even in low resource situations. But does that mean that surfactant and ventilation is a diminishing thing? No, not necessarily. Look at antenatal steroids and delivery of CPAP. No doubt, it reduces the need for ventilation or surfactant by 50%. Ventilators are not gone away. You would still need to ventilate children to give surfactant sometimes, though the indications are becoming lesser and lesser. Somewhere around 8 years ago, we realized many of these early term babies, gestation 37 weeks, obstetricians will say, baby looks mature, I think you should deliver. 24% of the times when we looked at our own data, they suggested that they had respiratory problems needing CPAP or some form of intensive care and sometimes surfactant also. So luckily at that time, the Royal College of Obstetrician guidelines also came about saying that antenatal steroids can be extended for elective cesarean deliveries to gestation up to 37.6 days, 6 weeks of gestation. So this is something you'll have to remember, that antenatal steroids now are being extended to late preterms and early term babies also. So when do you need surfactant and when do you need to intubate babies? CPAP is the good bridge, or NIV is a good bridge in smaller preterm gestations less than 28 weeks. There, if there is CPAP failure, that means the baby needs CPAP pressures of more than 6 or 7 centimeters water, there's severe retractions, and the child's FiO2 has gone to more than 60%, that's CPAP failure, and that kind of a baby will need mechanical ventilation and surfactant therapy. Now, surfactant therapy also, this last 15 years, people say, hey, you just want to give surfactant, why do you want to intubate for a long time? So Ensure is what most of us have been following, and many of you, I'm sure, are still doing it. You intubate for some time and then you would extubate soon as possible. But what the new kid on the block is still what is what we are following most of the time as far as possible in a NICU. If the registrars are capable and confident, they do what's called LISA. And most of the current time, this last 3-4 years, I've been doing workshops myself, is mostly on LISA workshops, which I demonstrated on mannequins like this here at the last national conference. So this is the LISA technique. Bear with me for a few seconds to see this video.
This video demonstrates the procedure of less invasive administration of surfactant in a spontaneously breathing, extreme preterm neonate. The gestational age of the infant is 27 weeks and the baby weighs 1 kg. The LISA is being carried out 2 hours after birth. The CPAP through nasal mask has already been in place since birth and continued during the procedure. 2.5 ml of reconstituted porcine surfactant is taken in a sterile 5 ml disposable syringe and is connected to a previously freeze-dried number 5 size inexpensive Romson nasogastric tube made of plastic, which is easily available in India. Initially, the laryngoscope with size 0 plate is gently introduced into the oral cavity under aseptic precautions and carefully advanced to visualize the vocal cords without the use of any aid. Thereafter, the nasogastric tube with surfactant is gradually advanced till 2 centimeters from the catheter tip into the larynx, and then the laryngoscope is gradually removed. Then surfactant is administered gradually through the catheter intratracheally while the infant is breathing spontaneously over a period of 30 to 40 seconds. The CPAP was not discontinued during the procedure, and the baby was closely monitored for complications like surfactant reflux, hypoxia, and bradycardia during the procedure. Immediately after the surfactant administration, the intratracheal catheter used to deliver the surfactant is removed and CPAP was continued. Close monitoring of all vital signs, SpO2 and blood gases are done after the procedure. The procedure is being carried out at the neonatal ICU of Manipal Hospital, Bangalore. This video demonstrates.
So you see, easily surfactant was being given by the laser technique, and most of our registrars with a little learning curve were able to do this. And we have adapted it to use some locally available catheters, though the LISA cath or the surf cath are also now available in this country, are a little costly, but nevertheless, they are available for us to use. So now you have a situation where this is non-invasive ventilation or CPAP being delivered to a child, and you can even give less invasively the surfactant. And LISA has been well proven now in meta-analysis that it's probably better than using Insure as a modality of giving surfactant by reducing the risk of death or BPD and ROP. So there we are. So LISA should be a mainstay. So this has now been sort of been a pleasure to publish this guideline from the NNF surfactant replacement therapy, which also I had the chance to review. And we are very happy to suggest that LISA should be probably a practicing modality for most neonatal units, both in the high resource and low resource situation. The next thing which is going to happen, and now the recent current consensus guidelines of the European Committee has suggested that you can use a laryngeal mask airway to give surfactant. So gestations about 1200 grams, it's been easily demonstrated, even without intubating, without really somebody knowing how to intubate a baby, you can use a laryngeal mask airway and you can give surfactant, and good improvement in oxygenation is noted. So it's now become a kind of consensus guidelines in the recent update on the European guidelines. We have had the opportunity to review laryngeal mask usage even in resuscitation, and this was published this year recently. So what I'm trying to say that slowly you'll realize that surfactant was the only reason you would need to intubate a baby. And even that now can be given through a laryngeal mask if you have the kind of facility or the technique or the kind of expertise to do that. But you are just going to wait for some more time. You'll see that surfactant can be given. Now, already the CureNup study is published that you can give surfactant through nebulization also, though it's a modest benefit. But nevertheless, just think of a situation. There's a small baby, you don't know how to intubate, you know how to do CPAP. You can probably give surfactant if it becomes cheaper later over a period of time. And hopefully, there should be a study we should be embarking upon now, multi-center trial, on trying to do this nebulized surfactant in this country and see whether it works in this country. So you have the whole gamut of situations. As a cartoon made by Satyan Lakshmi Narasimha, who's a close friend. You have a preterm baby, you have the target FiO2 which you need. Now FiO2 control automated available modalities are available through a microprocessor. You connect a pulse oximeter and it can you can set the FiO2 want, especially on a kind of CPAP device or on a high flow nasal cannula device, or sometimes in ventilators. It can keep the target saturation between 90 to 94. You have good nutrition going in. You have simple CPAP or HFNC or NIV going in. You have monitoring devices which are available, prevent infection, and the baby gets out of situation, and BPD need not be a fear anymore. Nevertheless, there's enough data now that all these strategies with very small numbers to treat are available, which show that you can get away, even if they get BPD in a small baby, you can get away by doing a lot of non-invasive ventilation. Now, the current data with antenatal steroids, delivery room CPAP, you don't have to fear BPD like the olden days about 15 years ago. So somewhere in mid 2015 or so, we had this opportunity to write the guest editorial in Journal of Neonatology that the way ahead is just possibly non-invasive ventilation, whatever modalities you use. You can use HFNC or NIV or CPAP or whatever. So if you now see the preterm respiratory support has come a big cycle back again. From, if you remember that first slide I showed you in the mid 60s, CPAP was mentioned by Gregory, but people disregarded it. People are more fond of ventilating babies. And finally now we have come to the same situation saying, you do CPAP. And most of the times, if antenatally steroided, given CPAP early, you would not even need to give surfactant to these babies. So in high resource situations now, and I'm sure many of my colleagues here are seeing this, gestations 24 to 26 weeks, 500-gram baby, early rescue porcine surfactants, all evidence-based, mind you. You give it aggressive TPN, minimal enteral nutrition starting on day one, you give CPAP, and lo and behold, by 8th to 15th day, the baby is in room air. And now, if you were to do the same data comparison between our unit or somewhere in the West, you'll find even gestations 26 weeks and less, we are able to bring about good intact survival, which we have shown based on some Bailey scores, which will publish very soon, that these gestations also we are getting good intact survival if we were to do what technology and what all we do in high resource situations like this. But the thing which now I'll just summarize now is babies who are gestationally poor, you need to start delivery room CPAP, going on to high flow nasal cannula. Absolutely no indication for using sustained inflammation, gentle positive pressure ventilation if needed. Delayed cord clamping definitely helps. All of you know that. Start with FiO2s of 21% to 30% in preterms and go up according to the saturation if required, otherwise go down. Early surfactant treatment. This is what we do in our NICU, typically starting with delivery room CPAP with a T-piece, blender, keeping the body poly-wrapped, transporting with CPAP and monitoring with a blender if possible, then doing T-piece, doing a kind of CPAP onto the baby or NIV and giving LISA to these babies, and they come out fairly well. And if you were to increase the respiratory support, non-invasive is always preferred, of course. If you were to increase the respiratory support, if the FiO2 is more than 30%, you need to give surfactant. But if you need to definitely ventilate babies, volume targeted ventilation is what most of us would be doing. And of course, if the baby is very sick, then of course, high frequency oscillation. But that's all more as a rescue therapy. Now, as far as surfactant is concerned, the technique LISA is much superior as we have shown it. And we'll probably give it if the FiO2 increases to more than 30% in the preterm babies or more than 40% in the little late preterm babies. And redosing depending on the baby's need for FiO2. If it's more than 30%, 8 to 12 hours later. Surfactant preparations, we all know that porcine probably works better in a dose of 200 mg per kilo. Recent data suggests that if the baby has early BPD or evolving BPD, you can give surfactant combined with budesonide endotracheally, and it helps the baby recover from BPD. We have standard flow charts which are available for RDS management. If the baby is spontaneously breathing, increase workup breathing, yes, start CPAP requiring more than 30%, switch over to NICU, go to a ventilator CPAP or continue the bubble CPAP, LISA or ensure if the FiO2 is increasing to more than 30%. And then if the baby, unfortunately, right at the delivery table is not breathing well, then maybe requires intubation, then give surfactant after that, and then ongoing ventilation subsequent to that. So this is just an algorithm. I'll probably share the slides so that Dr. Prashant can share it all with you. This is the supportive treatment. Again, the European guidelines recently published in November 2022 suggest caffeine, postnatal steroids, if the child has established BPD, especially dexamethasone or inhaled budesonide, antibiotics, temperature control, radiant warmer, polythene bag in the delivery table, less fluids, if possible, early parenteral nutrition, and trophic feeds. These are all the kind of inputs we need to give to support these babies, and these babies do well. This is the European guidelines. Of course, if you now see the recent European guidelines, again, it says LISA is what is recommended, and laryngeal mask surfactant administration has now come into the recommendation. This is not so in 2019, the earlier recommendations. Now in 2022, LISA has been brought into the recommendations. So if you were to now summarize, less is more is my kind of mantra, which I'm suggesting. Prolonged intensive care, prolonged intubation leads to iatrogenesis. Using central lines and all that, we try to avoid as much as possible, though aggressive TPN initially is required. Permissive hypercapnias, accept lower saturation in the first 10 minutes of the birth. 100% oxygen is no more good. Continuous monitoring modalities, avoid intubation, manage with kangaroo care most of the times. This is the book which was being referred to, where all these evidence-based medicine practices are available to be read. And for young fellows like some of you, you can probably go through this, and it's available on Amazon, and probably it will summarize most of the case-based scenarios if possible. The other things which have helped recover babies more non-invasively and better is pulse oximetry, of course. You have PtCO2, that is transcutaneous oxygen and carbon dioxide monitoring, which is available now. Capnography, we sometimes can do, instead of calculating blood gases all the time, we can calculate oxygen saturation index. Some of us, I have done some data on this, which again can tell you fairly clearly whether the child is going into respiratory failure or the child is recovering based, and it's very similar to the OI. You have point of care assessment tools available. The biggest challenge we had earlier was taking arterial blood gases sample using arterial lines. Now we have iStat machines which are available at the bedside. We can do arterialized capillary blood gases and do it more often if required. You have lung ultrasounds to tell us what is going to happen to these babies. This is a data which you had to just publish. One of our neonatology super specialty registrars has done this study, which shows that if the score on lung ultrasound of RDS is more, you have a definite reason for giving surfactant to these babies. The score is 5 or more. So this obviates the need to unnecessarily do X-rays and do more blood gases. So you can decide on giving surfactant based on lung ultrasound scores. PDA was a big problem in the olden days, and fluids was a big reason for that. We have shown, based on some of our publications, that you don't need to really aggressively treat the PDA. If at all, you can probably give paracetamol. So that itself tells us you become less aggressive with these preterms. Just leave them alone. Even if, for example, you have to do TPN, don't pull them out, don't get a X-ray machine and get the X-ray. You can just do ultrasound, so just check where is the PICC line lying. So many things have become non-invasive for babies. And this is, again, leading to better outcomes in terms of the brain. This is a recent meta-analysis which we published. The sicker the baby, more oxygen is given and more chances of retinopathy and more chances of chronic lung disease, and therefore more chances of neurodevelopmental outcome. 48 papers published in the world literature summarized suggest very clearly that if the child has severe ROP requiring laser or anti-VEGF treatment, that child has got a higher chance of neurodevelopmental outcome being poor. So if you prevent, therefore, oxygenation-induced toxicity because of being less aggressive and more closely monitoring, of course, the baby, you have a higher chance that the baby will have better neurodevelopmental outcome. So you have this resources situation about which I've been talking all along. You have gestations, 500 grams, 24 weeks. But still, even in high resource situations, you're doing bubble CPAP most of the time. So also in low resource situations, we should do the same thing, bubble CPAP. So look at it, you have equated, less is enough. You don't have to really. This is a great, great opportunity available. You have the private sector, you got high resources, you got the public sector, resources are less, but at least go and do non-invasive respiratory support for this baby, non-invasive modes of care, even monitoring like lung ultrasounds, and see if you can translate to a lot of other things like digitization, less invasive care, telemedicine, e-NICU, and all these protocols which are now available. Today's era is so full of opportunities. And I think we are probably looking at babies who can survive better in this country, both in the high resource and the low resource situation. The unfortunate problem in this country is the 1090 survival gap, as we call it. 10% of the resources only are available for 90% of the population, whereas for 10% of the well-to-do population, 90% of the resources are available. So technology definitely has come to play, and now you've been hearing more and more about artificial intelligence creeping into our practice. But what has helped babies survive all the time is quality of care and a lot of compassion and humaneness which comes into our care, which can make babies survive better. So with this, I just want to stop sharing my slides and very happy to ask my question. Thank you very much for the opportunity, Prashant, Reshma, and Som. Thank you so much. And Deepen, of course.
Thank you so much, sir. It was such a lucid and excellent presentation. I mean, I felt like I have been watching a movie of last 50 years of respiratory care in preterm babies. And I mean, starting from, invasive ventilation to the surfactant, CPAP, HHFNC, LISA, all these various methods and, various data with regards to the outcomes. And it has been really excellent presentation, and I really learned a lot, and I'm sure everybody has been benefited by this session. So thank you so much, sir. We are almost like 1 hour since we have started, and we are supposed to finish at 4:30, but there are not many questions. Like just I have 1 or 2 questions from the audience. So one question is from Dr. Sameer, who is a DM resident in our institute, that you showed an excellent video about the technique of LISA, and when performing this, have you experienced any problem with intrapharyngeal reflux of the surfactant?
No, I mentioned this very clearly. In fact, LISA is a kind of learning curve. Initially, it takes some time. But now, in fact, if you ask my registrars, we have not had any, even the earlier days, since we are very, very aware of this problem which can happen, we've been careful. We're not had any expert. In fact, a lot of institutions, like in our own city, St. John's Hospital Medical College, they use only LISA technique. And I've been talking to them. We have not had any problems at all. Nothing at all.
Okay, sir. And the second question I had, so once you kind of inserted the laryngoscope, inserted the feeding tube into the right length, into the trachea, you have removed the laryngoscope and then given the surfactant, as it was mentioned, given within 30 to 40 seconds. So like normally, traditionally in Insure, what we have been taught or what people are practicing is giving surfactant in 4 aliquots and then doing
we just give it very slowly, and that's it. You saw the entire video. You see the entire procedure took that much time.
And what is your take on giving surfactant slowly over through the endotracheal tube instead of giving in aliquot? So what is your opinion on that?
We have done this earlier, much before LISA we started. Last about 3 years, we are doing only LISA. Earlier, we have not really necessarily done Insure as the way it was described, like typically connecting and then pumping the surfactant. Earlier days, we would even use an ambu bag to. So earlier, once we started realizing acute lung injury may happen, we would take it in a syringe and give it very slowly, like what you're doing, the Lisa here, in an intubated baby. We have done this before. But
Okay.
after that, we'd connect the baby back to the ventilator. But
Yeah.
we've stopped doing that also now.
Okay. So there is basically no need to give surfactant in aliquots. It can be given just very slowly,
Very slow.
either through the endotracheal tube or through the.
But I wanted to mention here, the Lisa is mostly for the low volume surfactant, which is the porcine surfactant.
Yes.
So the data is on that. So large volume like Cervanta or bovine, you'll have to be a little careful and very slow. But
Sure.
still it is doable.
Sure, sir. Sure.
So there is one more question that somebody is asking regarding a nebulized surfactant. Should it be used or not?
I mentioned that there's a vibrating mesh nebulizer, the picture of which I showed. That is where the CureNeb study was published. They used the porcine surfactant, and unfortunately, it showed only modest benefit. That particular nebulizer is a little difficult to procure, but it's a very good nebulizer. But then again, we are going this. I showed a small kind of slide on that slide that we are now submitted a proposal for a aerosolized surfactant study. If we get funding for that, we may use bovine surfactant using an ordinary nebulizer, which is a simple nebulizer, and see if it is possible to use it. So in that case, it'll become very, very good in the low resource situation in the periphery. You have a CPAP going on and you just connect a surfactant. But I'm not advocating it right now till you use a vibrating mesh nebulizer as what was shown in that picture. You can read the CureNeb study. It's published about 3 years ago.
So one more question is, you have mentioned that in a preterm, FiO2 of more than 30% on CPAP is indication of surfactant, right?
No,
So
that is in gestations 28 weeks or less.
This, yeah.
28 weeks and above, up to 40% you can wait.
So the question asked by the person is that, can we wait if we are not having surfactant on CPAP only? And what is the cutoff maximum FiO2 given
There's
on?
nothing like that. You can, people have gone on to 60% also. It's just if you don't have surfactant, you just give CPAP. That's fine. A good applied CPAP should be good enough. I'm not saying, but the time spent on the CPAP then will be longer. That's all. But I think it's okay. If you don't have that, please continue only CPAP.
Last question. Any role of nebulized budesonide along with Budecort along with the surfactant?
No, the only study which was published, which is the one I showed you, it's a meta-analysis also now published on surfactant mixed with budesonide as a liquid preparation given intratracheally to in established BPD at 2 weeks of age, approximately. It reduces the severity of BPD and gets the child off the oxygen faster. But studies are probably going on with nebulized surfactant and along with the budesonide. This is inhaled surfactant. But I'm not sure about the data now.
Thank you so much, sir.
So just one more last question while we are discussing BPD is somebody is asked to hear is a timing of postnatal steroid in patients with BPD.
So this is the European study guidelines. It's just been published 2022, which suggests by 2 weeks. I'm not still sure. I've not read it enough. But I would say 2 weeks in established BPD, you can give parenteral steroids.
Okay. Okay. Thank you so much, sir.
Sir, one more question is there on you.
You are muted. Dr. Prashant, you are muted.
Yeah.
Sir, one more question on YouTube. Pinky Datta is asking, sedation, what to give and how much to give?
Sedation is an ethical issue, especially, in fact, tonight we are going to talk at another fora, the IN Neonatology series. Our unit is going to talk about pain and sedation in newborns. As you start realizing that more and more high resource situations, you're doing better and better fine-tuning the care, including nutrition, all that, you start realizing that babies do feel pain. More so, preterm babies do feel more noxious and noxious insults. And that leads to poor behavioral issues later and the neurodevelopmental issues later. So you start getting sensitized for pain and sedation during procedures, especially, which we do as a routine in our this thing. It could be pharmacological measures like fentanyl and all that during ventilation or during procedures, or we do non-pharmacological like KMC, breastfeeding, sucrose, those kind of things. But I think we had to become sensitized about this. The only thing is this Lisa procedure, which you saw us being doing, we had not sedated children. So this has become a little ethical issue because many units across in the world, they don't sedate babies. They think it's so simple just to do it rather than sedating. But at least we should try to do a little sucrose or something and then give a little relief to the baby. I think we are convinced that babies do feel pain and we have to be sensitive to that.
And sir, just very last question. There's one question pop up just now, is that in a resource limited setting, when there is no availability of T-piece or a blender in a delivery room, is there any other way to give delivery room CPAP? Any alternative?
The RAN cannula which I showed is so inexpensive. It's ubiquitously available. You just connect it to a simple, of course, you don't have a blender, at least do that. That is going to give you some CPAP. Unfortunately, the problem with the RAN cannula is not enough data, robust data is available. So people shy away from using the RAN cannula. But in resource limited situation, you can put a good well-fitting RAN cannula, which will cost you just about 200 rupees. It's freely available in India. Most of the conferences, it is being sold. You just get 5-6 of them and use it, connect it to the oxygen. At least you do that. What you can do is to make sure you don't get 100% oxygen, you have a pulse oximeter. You connect the oxygen flow meter to the RAN cannula, but put a Y connection so that some of the oxygen air leaks out. So that some only is going to the baby. So that way you reduce the quantum of oxygen going to the baby and continue a FiO2 monitor. I think you should just use that. Just use that.
Sure, sir. Thank you so much, sir. Thank you.
Yeah.
Thank you. It was a pleasure. Thank you so much for this opportunity.
Thank you.
Thank NNF Gujarat.
Yeah, thank you so much, sir. We never realized that it was almost an hour. You were talking so lucidly and all the points were so relevant. So on behalf of NNF Gujarat, we would like to present a certificate of appreciation. Can I request Sagnik to present a certificate? So on behalf of NNF Gujarat, we present a certificate of appreciation to Dr. N. Karthik Nagesh sir for being an expert in neonatal Pathshala. The lesson from experts, respiratory care of preterms, the next paradigm, less is more, of NNF Gujarat State Chapter on 22nd February 2023. Thank you so much, sir.
Thank you, Prashant. Thank you, Deepan. Thank you.
Yeah, and we also present certificate to our moderator, Dr. Reshma Pujara, for moderating the session so well. So thank you, Dr. Reshma also.
Thank you so much, Dr. Prashant.
Thank you,
everyone. We will be meeting on next Wednesday, same link, a ClearNet link and YouTube link. So we will be meeting next Wednesday. Next Wednesday, we are having a PG seminar that is on NEC, necrotizing enterocolitis. A student will be presenting and we will be enjoying the PG seminar. So thank you on behalf of NNF Gujarat. I request Dr. Dipen Patel to end the session. Thank you.
So thank you, Karthik Nagesh sir, because it was an excellent talk. It was really like a journey and you incorporated the thoughts like you are teaching us. So I think this lecture will remain on YouTube for a longer time and we all have, we will all to see again because there was so much information you delivered in a very short time. And thank you, sir, for this kind of lecture because we have never learned in this kind of way. Thank you very much, sir. Thank you, Dr. Reshma, for moderating the session. Thank you, Prashant.
Thank you, Dr. Dipen. Thank you.
Thank you. Thank you.
Yeah. Thank you once again to one and all. And Sagnik, we can end the meeting. Yeah.
Thank you, Sagnik. Thank you.